Hello, my name is Patrick and I'm a Pulmonary Critical Care Fellow. This video is on assessing a patient's effort and anaerobic threshold as part of a CPET. It's important to remember that it is our cardiac output which normally determines our exercise capacity. So in scenarios where a patient has a low VO2 or low anaerobic threshold, we need to assess their effort. And ways in which that we can do that is that we can firstly look at what percentage of their predicted heart rate max that they achieved. Secondly, we can look at what percentage of their predicted work rate max that they achieved. And thirdly, we can look to see if they reported a sufficient amount of exhaustion on a validated scale. Pulmonary markers of a patient's effort include their respiratory exchange ratio. If the peak is greater than 1.1, it typically signifies that they made adequate effort. We can also look to see if they achieved their predicted VO2 peak and for the presence of a respiratory compensation point. The respiratory exchange ratio peak greater than 1.1 is bolded because this is a widely used measure of effort, while values can vary. This is the 9-panel plot. It has been rearranged in the last few years, but each of these panels helps us interpret the test in different ways. I'll be going through each of these panels throughout this video series, but today we'll just be focusing on a few of them. Before we get to those panels, I just want to talk about the different phases of a CPET. The initial phase, the rest phase, is when the patient has been fully strapped in and allows for any anxious hyperventilation or tachycardia to subside. This is followed by unloaded cycling, followed by the increasing workload during the actual test where they reach their peak, followed by a recovery phase. And what I want you to keep in mind are these three vertical lines, 1, 2, and 3, because you will see them in all of the 9-panel plots. This is the first panel, or panel 1, and this is looking at the work rate. So those green crosses that you see are signifying the work rate as it increases, and during exercise our VO2 increases at a rate of about 10 mils per minute per watt. A lower rate may indicate an impaired O2 transport and/or circulatory impairment. The volume of carbon dioxide we produce closely correlates with the VO2, but does show specific patterns below and above the anaerobic threshold. Below the anaerobic threshold, which is roughly here, the volume of carbon dioxide produced increases at about the same rate as the volume of oxygen consumed, or the VO2. Above the anaerobic threshold, the VCO2 increases at a higher rate than the VO2 because of that additional carbon dioxide from anaerobic metabolism. And then during recovery over here, we have the VCO2 decreasing less rapidly or less quickly than the VO2, and this leads to an abrupt increase in the respiratory exchange ratio, which I'll talk more about in a minute. This is our respiratory quotient. It is the VCO2 divided by the VO2. If the goal of metabolism is to release hydrogen ions to produce ATP, then it makes sense for us to predominantly burn fat, which is very rich in hydrogen. If we compare glucose, which has 12 hydrogen ions, to fat, which has 32 hydrogen ions, this is evident. At rest, we burn fat because it's plentiful and provides this high yield. But during exercise, we burn glucose, which is already half oxidized. Here you can see it only needs 6 additional molecules of oxygen to complete the process, compared to fat, which needs 23 molecules of oxygen to complete the process. And that's why it's kept for exertion, when oxidizing fat would take too long and need too much oxygen. Now, when we divide the VCO2 by the VO2 for each of these substrates, you can see that for glucose, the respiratory quotient is 1, and for fat, it's 0.7. At rest, we typically say we have a respiratory quotient of about 0.8 because we're burning a combination of both. And during a CPET, we infer that this is happening by looking at the respiratory exchange ratio, by measuring the gases inhaled and exhaled at the mouth. Now that we understand more about the respiratory exchange ratio, sometimes referred to as OR, let's look at panel 8. During exercise, we should see a progressive rise to values exceeding 1 for patients able to exercise beyond their anaerobic threshold. This reflects the additional production of carbon dioxide from the buffering of lactic acid, but this may not occur if exercise is limited by symptoms or poor motivation. Immediately post-exercise, the VCO2 decreases less rapidly than the VO2, and this leads to an abrupt increase in the respiratory exchange ratio, as you can see over here. Now, if we look at the point where one is crossed, we can see that this is around the 12-minute mark. In the hierarchy of methods to determine the anaerobic threshold, this is generally considered the least accurate and least specific method. Here it appears to be at the 12-minute mark, whereas on other plots for the same patient it appears to be closer to 10 minutes. The reason for this is that there is a buffering lag. Carbon dioxide is highly soluble, so there is a delay between when lactic acid is produced and when the carbon dioxide is actually measured at the mouth. Also, it's susceptible to volitional breathing. If a patient is very anxious and hyperventilates, then the OR will skyrocket to 1.1 or 1.2 within the first couple of minutes, long before they've actually reached a metabolic threshold. It does, however, help us with a few things. It gives us insight into their metabolism. 2, it helps us estimate the intensity of their effort. And 3, it helps us detect erratic or dysfunctional breathing, which you can see in the bottom right by this very non-linear, varied pattern. Now we'll look at more reliable methods for detecting the anaerobic threshold. Here we're looking at panel 3, and this is the V-slope method for looking for anaerobic threshold. It's considered the gold standard, and here we're looking for the inflection point where the VCO2 begins to increase disproportionately to VO2. So if you were to trace a line here and then trace a second line here, you can see that there's a change in axis, and this is where the anaerobic threshold occurs. We can look at panel 4 for the ventilatory equivalents, specifically looking for the nadir of VE-VO2 or the ventilatory equivalent for VO2. This is highly sensitive and usually occurs right at the anaerobic threshold and is considered to be the point of maximal ventilatory efficiency. Both of the ventilatory equivalents decrease from rest to mid-exercise and then increase later in exercise. Let me show you. So here they are at rest, decreasing and then increasing towards the end. And this initial decrease reflects improved ventilatory efficiency for 2 reasons. 1, there's a reduction in the effective dead space because there's an increase in tidal volume, and 2, there's a reduction of high VQ regions in the lungs because there's recruitment of pulmonary capillaries that were underperfused at rest. This red line shows and pink arrow show the nadir of the VE-VO2 and identifies the anaerobic threshold, or the VT1, and this is where the ventilatory drive starts increasing relative to the VO2 because of this excess VCO2 from anaerobic metabolism, usually around mid-exercise, and this is the start of the period known as isocapnic buffering. A last option for determining the anaerobic threshold is to look at panel 7, looking at the end-tidal gas pressures, specifically looking for the point where the end-tidal O2 starts to rise without a corresponding drop in end-tidal CO2. This helps us identify the anaerobic threshold. Now we'll look for evidence of the respiratory compensation point, or the ventilatory threshold number 2. Here we're looking for the respiratory compensation point on panel 6 that plots minute ventilation relative to VCO2. The slope of this is essentially linear over most of the exercise and reflects overall ventilatory efficiency. Here you can see there's one axis, and then later with maximal exertion, when the available bicarbonate to buffer the CO2 is exhausted, we see there's an upward inflection. And it's at this point of the upward inflection that chemoreceptor mediated hyperventilation takes over and the isocapnic buffering period ends. Now we're going back to panel 4, looking at the ventilatory equivalents. Instead of looking at the ventilatory equivalents for VO2, we're looking at the ventilatory equivalents for VCO2. And again, with maximal exertion, when the available bicarbonate to buffer CO2 is exhausted, we see there's a nadir of the VE-VCO2, and this helps us identify the respiratory compensation point, or VT2. Again, this marks the onset of chemoreceptor mediated hyperventilation and the end of the isocapnic buffering period.